So you can see my screen right now?
Yes.
Perfect. Okay. So good afternoon, everyone. I'm really happy to contribute to the first transfusion meeting in Annaba, and many thanks to Dr. Hassan and the organizing committee for inviting me to present on this topic. So the topic is about the approaches to secure plasma-derived medicines in low middle income countries, which is now the focus of the International Society of Blood Transfusion, as well as the World Health Organization, in order to improve the utilization of the domestic plasma and secure these important medicines. So these were my disclosures. Now, so as we all know that we can have the plasma recovered from whole blood donations, as well as being collected directly from the blood donors by apheresis. The latter is mainly used to provide the plasma to industry. In the first one, the plasma recovered from the whole blood, this needs a lot of qualification in order to be used in industry. So I don't know if I have next, please.
Yes.
Yes.
You are with us.
Yeah. Can we? Yeah. Can we go one slide behind?
Yes, yes, sure.
Yeah, one slide back, please.
But it's your presentation, so you are going to pass it like you want to.
No, now I have control. Thank you very much.
Okay, thank you.
So the indications for clinical indications for plasma transfusion is limited to massive transfusion situations in the reversal of patients on warfarin therapy who have intracranial hemorrhage, in the replacement of coagulation factors in the absence of factor concentrates, such as the situation with the factor V deficiency, and in therapeutic plasma exchange due to thrombotic thrombocytopenic purpose. And in the meantime, there is some adverse events related to plasma transfusion, like transfusion-related acute lung injury, transfusion-associated circulatory overload, allergic or anaphylactic reactions, and other less common risks, including transmission of infection, febrile non-hemolytic transfusion reactions, red blood cell alloimmunization, and hemolytic transfusion reactions. In general, in our region, in the East Mediterranean region, we practice the preparation of packed cells, and so there is a lot of recovered plasma, and due to the limited indications of plasma transfusion, there is usually a big stock of plasma that's not utilized and that needs to be qualified for fractionation by industry. In some countries, this is limited by aspects like the lack of GMP, as well as the lack of repeat voluntary blood donors, because to qualify plasma for fractionation, this plasma has to be held in quarantine until the donor comes back and proves that he is healthy as for the previous donation to release the previous donation. In the meantime, we would like to briefly discuss the global access to plasma-derived medicinal products and the situation of inequality. So if we look to, for example, to factor VIII consumption on the global level, we find that countries in the North America, Europe, and the West Pacific, which represent about 35% of the global population, utilizes more than 80% of the global production of factor VIII. And the less than 20% is available to 80% of the global population, which poses a huge lack of access to the product to patients with hemophilia in the developing countries. Same situation is happening with the immunoglobulins, the intravenous immunoglobulins, where the majority of the products are consumed in North America, Europe, and Asia Pacific, and very little in Middle East and Southeast Asia, Africa, and many countries in South America. And this situation is expected to be continuing according to Marketing Research Bureau up to 2026, and I think beyond this. So taking into consideration all these challenges, the World Health Organization published last year a guidance on increasing supplies of PDMPs to low, mid, and middle income countries through fractionation of domestic plasma. In this guidance, there is, I mean, it includes importance of these medicines, the strategies to obtain plasma for fractionation, the standards and the quality management in blood establishments, country bilateral and regional cooperation, like in our region, for example, in Middle East, if we can, and North Africa, if we can cooperate to establish one huge plasma fractionation facility, and then we unify the quality parameters of the plasma collection and use this domestic or this regional fractionation facility for producing plasma-derived medicine. This situation is, for example, happening now in South Africa in collaboration with the surrounding countries, and in Latin America, in Argentina, where it fractionates for several countries close to it. It also describes the plasma for fractionation, and as well as some other alternatives to have plasma products or plasma components, virally safe plasma components that can be substitute or the plasma-derived medicines, as is seen here in this paragraph in section 9 of the document. I'm afraid that sorry, there is a, yeah, I will go back. So I will focus during the coming part of the presentation on a concept that we developed in Egypt and was acquainted by a Swiss company, a concept called mini pool plasma fractionation to enable national blood establishments to produce safe plasma coagulation factors and immunoglobulins. The rationale is to improve the utilization of wasted fresh frozen plasma in low middle income countries through local mini pool fractionation in validated sterile medical devices. So these medical devices are produced by this company. It is validated for viral inactivation and purification of the plasma proteins, mainly the coagulation factors and the immunoglobulins. So in the blood banks, we separate the fresh frozen plasma to cryoprecipitate and cryopour plasma. Using these medical devices, we can pool 35 units of cryoprecipitate, subject them to solvent and detergent treatment, and then remove this solvent and detergent chemicals and filter them through purification and bacterial filters to have solvent, detergent, and microbially filtered cryoprecipitate. The cryopour plasma can be subjected to caprylic acid, which is a virally inactivation step, and in the meantime, it precipitates all proteins and purifies the immunoglobulins that can be pulled into an ultrafiltration device and then concentrated and then filtered again for purification to obtain mini pool intravenous immunoglobulins. So this is the schematic of the virus inactivation device for mini pools of cryoprecipitate, which includes a back cascade that includes an absorption filter for purification and bacterial filter, in addition to the chemicals and the extraction agent for removing the chemicals after the virus inactivation. The immunoglobulin is happening through, sorry, I lost the, yes, here, three medical devices, pooling bags for caprylic acid virus inactivation and purification of immunoglobulins, ultrafiltration cascade that can concentrate the immunoglobulins to 5%, and then a filtration cascade. And then we end from a batch of about 4 liters of plasma with about 20 grams of IVIG that can be sub-allocated into these small bags in order to stock them and we keep them frozen. Sorry. There is some delay in the, yeah, sorry. Sorry for the technical difficulty. By any means, I mean, this, yes.
Are you having some troubles?
Yeah, now it's better. So I will show some of the experience in Egypt of using this technology. So we published in 2018 about the experience of using these medical devices for the virus inactivation and purification of the cryoprecipitate to obtain factor 8, von Willebrand factor, fibrinogen, and factor 13. Sorry, it's a little bit frozen.
In fact, we can hear you, but we are seeing the other.
Yeah, I will go back to just a minute. Yeah.
Yes.
Yeah. So the experience with this is during this period, we processed about 300,000 units of dry cryoprecipitate using about 8,000 medical devices, and we could produce with this about 36 million units of factor 8 at a cost of $2.5 million. The cost of importing similar amount was $5.4 million with a direct saving of about $3 million. And the product was very safe. It was like the factor concentrates, and the striking that it was also very safe immunologically. So in trying it with 20 severe hemophilia A previously untransfused, none of them developed inhibitors, which is compared to the rate of development of inhibitors of around 30% with the industrial product. So this was a very striking observation for us. For the immunoglobulins, we have done a clinical trial for treatment of ITP, which was a prospective randomized multi-center study comparing the mini-pool IVIG to the standard IVIG. And it was published in Transfusion, I think in 2017, and showed that the safety and the efficacy of the mini-pool IVIG was comparable to this of the standard product. We have just finished a study on using the IVIG, mini-pool IVIG in the management of 20 kids with primary immunodeficiency. And the study continued for 6-month infusions, which showed that we could achieve a trough level above 500 milligram per deciliter, which is enough to protect the boys against severe bacterial infection, and as well as that it showed that the quality of life of these boys dramatically improved when they were put into this mini-pool IVIG prophylactic therapy to prevent infections. So in summary, the low middle income countries usually have a surplus of plasma and in the meantime suffer from inadequate access to plasma-derived medicinal products. WHO advises LMICs to work towards local preparation of PDMPs and or safe alternative plasma products, among which is the mini-pool plasma fractionation. This fractionation technology is now developed and has been successfully implemented in Egypt, and it offers developing countries, and we are going to start another pilot study or pilot implementation in Dakar with Professor Salid Diop. We hope that we will achieve this towards the end of this year. And so we can offer developing countries an access to use domestic plasma for local preparation of plasma products with equal safety and efficacy to PDMPs. It can be an intermediate step in the preparation for large-scale plasma fractionation projects. And the IVIG medical device can be a practical tool to prepare hyperimmunoglobulin from convalescent plasma in epidemic areas, and also can be used to prepare strategic components like the anti-hepatitis B and the anti-D. With this, I thank you very much. And thank you again for inviting me to present. I'm sorry that I was talking in English and not in French. Thank you very much.
Thank you.